Okay. So everybody sees my screen, hopefully, right? So this being shared. Let's say, hopefully. Okay, thank you. Okay, so let's go ahead and get started with our urinary system in terms of what is the main functions for that. So when we talk about urinary system, the main organ that actually does most of the jobs in our body is going to be your kidney. And what your kidneys are going to do are some of the main functions are listed here. So first one is maintaining the chemical consistency of your blood. So that's we're talking about kind of those electrolytes that I mentioned earlier. So like sodium, calcium, potassium, these are ions, electrolytes, or salts, however you want to call them, basically. Those are the ones that are basically going to be maintained at a very specific number and or very specific range, I should say. And your kidney is responsible to make sure that range is maintained. The other thing that needs to be maintained is your pH. So pH again is the measuring of the acidity or alkalinity of your blood. So your blood needs to stay at a slightly basic or alkaline environment, which is about 7.35 to 7.45. For us to be able to maintain that, we need to be able to basically get rid of extra component that might be acidic or super alkaline. And your kidney would be responsible for removing those components out of our system. Of course, the most common one is basically filtering most of the volume that we have in our body, and that volume is represented in form of blood. You also remove your toxic material produced by your metabolism and excess water from the system. A quick note again, when we're talking about that metabolic waste, I have listed two of them here, or actually three, sorry. Urea and creatinine, they're two main waste product or metabolic waste product produced as a result of protein metabolism. And then uric acid, which is another one, is a byproduct of breaking down nucleic acid, which are basically your DNA and RNA. So if you have ever done a urine test, one of the first things they actually measure is the amount of urea, because that's the most common type of waste product you will see in urine. And if your kidneys are not functioning properly, that urea volume can be significantly less than what it's supposed to be, which basically means it's staying inside your system and your kidneys are not functioning very well. So let's move on to the organs. Urinary system is one of the more simpler organs in terms of the number of organs that are involved, especially if you're coming from digestive system. So you have two kidneys, one on the right, one on the left. You have these tubes that are coming from your kidneys with the goal of collection of the urine called ureters. So we have one from each kidney. Ureters find their way to the urinary bladder, which is this kind of heart-shaped organ you see right here. And eventually, bladder basically is going to hold urine. It doesn't really have any special function. And when the bladder is basically full, it gets excreted, urine gets excreted from the body through the tube called the urethra. Please make sure you guys distinguish between ureter and urethra, because that's the most common mistake I see in the exam, mistaking those two tubes with each other. Now, when I'm looking at the location of the kidneys, they are partially protected by the rib cage, as you can see in your image. They're protected by your rib 11 and 12, which we previously identified as your floating ribs. So they're only basically extend to the back, which is where your kidneys are located. In terms of their location in associate with your vertebra, they're located at the T12, which is the last vertebra of the thoracic region, and then lumbar 1 through 3. The kind of the indentation that you see in the middle of the kidney, this little kind of indentation that gives it that kidney bean shape or I guess bean shape at the center, that little indentation is refers to as, it refers to as hilus or hilum. Again, that's that concave surface where either the ureter is exiting or the blood vessels are coming in or out. And lastly, if you actually take out or do a dissection of the urinary system, you actually can see this really thick fibrous layer surrounding your kidney. It's called renal capsule or fibrous capsule. Again, fibrous means protection. And this layer is basically protects the kidney or provide partial protection for the kidney. So if you're looking at the gross anatomy of the kidney, this is an actual human kidney, you can see, and this is a more clean image of it here. So what you can see is the edges of the kidney, which has the lighter shade of pink, and then the inside of the kidney that has this kind of triangular structures in a darker red color. So the edges of your kidney is referred to as the renal cortex. So the edges of your kidney are called renal cortex. I'm sorry, I don't know why my mouse is doing this. And the inner portion of the kidney, so this portion right here, this is called renal medulla. So all of these together is called renal medulla. But what if I ask you, what is these individual triangles are called? So what is the individual structures on their own called? They're referred to as renal pyramids that are within the renal medulla. So renal medulla as a whole, and then individually they're called renal pyramids because, you know, the shape of the pyramid, those triangular shape. Now you also have extensions of the cortex, which is basically, here's your cortex at the edge. You have these extensions that comes between your pyramids, right here, right here, right here. These are called renal columns. So right now, what we're talking about basically is just by looking at the kidney, there's color differentiation, and those are gonna help you identify different regions of the kidney. It becomes clear why we're talking about here when I start talking about the microscopic structure of the kidney called nephron. Now, again, the main job of your kidney is to basically do all of the jobs we listed, and as a result, produce what we call urine. So get rid of extra water, balance your pH, balance your ions, get rid of metabolic waste. Everything that happens in the kidney, the final product that is being produced is called urine. So urine needs to be collected by the kidney. So how is it going to get collected? So first of all, it gets collected by these small structures you see right here, these individuals. So I'm just going to point them one by one. So here, 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 right here, right here, and right here. These are called minor calyx. Minor calyx. They're typically located at the end of each of your pyramids. Now notice here, as I go from this minor calyx and this one, they're coming together and merging together to form a larger section right here. So when two or multiple minor calyces join each other, like you can see here, 1, 2, and 3 merging together to form one, the larger tube is referred to as the major calyx. So minor calyx, and then minor calyx leads to the production of major calyx. This is the path of urine, remember that. Now, you have major calyx, major calyx, major calyx. All of them get dumped into this central part right here called the renal pelvis. So renal pelvis is this kind of funnel shape you see right here, and that eventually work its way to the ureter to take the urine out of your kidney. So if I ask you as of right now, write the path of urine through the urinary system, as of right now, let me connect my thing so I can write it down for you guys. as of right now, the path of urine that you guys are familiar with would be minor calyx going to major calyx, sorry, to renal pelvis. Renal pelvis empties into the ureter. Ureter empties into the urinary bladder, and then bladder eventually excretes the urine through a tube called the urethra. Notice I left some empty space on the top because there is a couple of structures that sits behind that are microscopic. Is there any question about this so far? Any clarification on anything we discussed? Okay. So up to this point, what I have discussed with you guys are what I can basically look at a kidney and identify structures like cortex, major calyx, minor calyx, medulla, pyramids, etc. But what about the microscopic structure? The structures that are actually giving me the ability to produce urine, and that urine being collected by what we have listed here. So those microscopic structures that are basically create urine are known as nephrons. Nephrons are going to be my functional units that produce urine. And we're gonna spend most of the lecture on nephrons, so on the microscopic aspect. Now, for us to understand kidneys, one of the first things we need to understand first is that you need to bring blood to your kidneys and eventually to your nephrons, which are the ones that are actually producing urine, and then eventually take the blood that has been filtered out of your kidney. This is really important. I'm going to say it one more time, guys. I need to provide a pathway for blood to first enter the kidneys, continue forming a smaller and smaller branches until it reaches individual nephrons in my kidney. Allow the nephrons to filter and clean the blood, and then take the same path out of the kidney. Now, what is this path that your blood is going to take into the kidney and eventually out of the kidney? So we're gonna follow this. We're gonna start with what we identify as renal artery. So renal artery is basically bringing blood that needs to be filtered into your kidney. It is also bringing oxygen to your kidney so the kidney can basically function. So renal artery, as it enters the kidney, it's forming minor branches. So it starts to branch almost immediately. So these branches you see right here, and there's another one right here, is called segmental artery. So we're starting with renal artery. Renal artery branches into segmental artery. Now this segmental artery, if I track one, goes between the pyramids that I have. So these were my pyramids. They run between my pyramids right here, and they're called interlobar artery. Interlobar artery, as in they're going between the two lobes. Eventually, this blood vessel, again, if you follow it, is gonna go in the border between the medulla and the cortex. So these lines that you see right here, basically the border of, again, medulla and cortex, these blood vessels are called arcuate artery. So this is number 3, goes to arcuate artery. Now, arcuate artery is going to form these branches right here that kind of radiating into your cortex, called cortical radiate artery. Look at the name, guys. Cortical as in cortex, radiate as in they're radiating, you're going into it, radial artery. And then lastly, you're forming these tiny, tiny branches right here, these side branches right here, and these are called, I don't know if I actually named them in this picture. They haven't named them in this picture. They're called afferent arterioles, and I'm gonna show them on the next picture for you guys. They call afferent arteriole, and I'll tell you guys why they're not shown here in just a second. Now, eventually, again, the nephrons are gonna do their job, and they're gonna do what? They're gonna take that blood and eventually form their way back out of your kidney. So at that phase, what I'm gonna do? Cortical radiate artery, which were the red ones right here, gets replaced by the cortical radiate vein. Okay, cortical radiate vein form their way to, again, literally backtrack it identically. So they form the arcuate vein. So here is my arcuate vein. Arcuate vein form their way to the interlobar vein, which is these ones right here. And here is the trick part, guys. In the artery, we had interlobar going to segmental artery, but there is no segmental vein. So you go from basically interlobal vein, which is number 8, to renal vein, which is number 9 on our list. So there is no segmental vein. Okay, that's the main difference. Everything else that I've described here is identical. Renal artery, renal vein. Interlobar vein, interlobar artery. Arcuate vein, arcuate artery. Cortical radiate artery, cortical radiate vein. The only thing that is missing is the segmental artery does not have a pair for the vein. Are we clear so far, guys? Any clarification on anything? Please ask if something is not clicking. Good, okay. So this is the path that I showed for you guys. You don't have to know the aorta or the inferior vena cava because they're basically part of outside the kidney, and I wanted to just focus on the kidney. So again, you have renal artery, segmental artery, interlobar, arcuate, cortical radiate, and then again backtrack, cortical radiate, arcuate, interlobal, and then renal vein. Now, one thing that I want you guys to, by looking at this picture, that becomes very clear is the fact that there are other blood vessels that are in this path. The difference is what we have boxed out here. These are identified as microscopic blood vessels. So these are not the ones that I can open up a kidney and then color my blood vessels and visibly see them on my kidneys. These are microscopic. They're known as afferent arterial, glomerulus, efferent arterial, and then peritubular capillary, also sometimes called vena recta. And then this is basically the path for the microscopic blood vessels that you're present in your kidney. So pay attention to this, guys. If I'm asking you for writing the path of macroscopic blood vessel, macroscopic as in gross anatomy, is what I've listed for you here. But if I ask you write the full path of blood vessels through your kidney in and out, then you must include the afferent arteria, glomerulus, efferent arteria, and peritubular capillaries. And I will talk about this. Don't worry. Like, I don't understand how these connect together. Don't worry. I'm going to talk about it in just a minute, and hopefully everything comes together. We just have to start from somewhere. Okay. So let's start by looking at our nephrons. So we keep saying that if I want to produce urine, my kidney is responsible for that urine. But at the microscopic level, the part that is responsible for it are going to be my nephrons. And again, nephrons are going to be the basic units of my kidney that produce that urine. Now, when I look at a nephron, there are two main structures that can be found inside the nephron. Part that is called renal corpuscle, not renal capsule, because that's, again, common mistake I'm going to see. Renal corpuscle. And the second part is renal tubules. renal corpuscle and renal tubules. And the word tubules automatically should kind of trigger you. I'm going to see a bunch of tubes, right? And the word renal implies your kidneys. Now, whatever comes out of my nephrons, so when my nephron is done with whatever fluid processing it needs to do, the product that enters the next part called the collecting duct would be called urine. So when your body basically produces urine, it's when it starts from the collecting duct. So it receives urines from the nephrons that you have up here. And it's very important in producing or conserving body fluid when you are dehydrated. And again, I'll talk about it briefly, but you'll learn about it more in physio. So let's go ahead and just take a look at a nephron, because I think it makes it a little bit easier. So nephron, we said, it made up two main parts. So I'm going to list them for you guys in the picture. You have this circle right here. So this circle is called your renal corpuscle, right? As I mentioned in the previous thing, renal corpuscle. And then notice right here. So you have from here all the way to here. So all of these tubes that you see right here are referred to as what? From here to here are called renal tubules, which is the second part of your nephron. Are you with me so far, guys? Is there any question? Because we're gonna build on this. So if something is not clicking now, it's gonna get more complicated. So I don't want you guys to go. Good? Okay. So let's start talking about your renal corpuscle. What is inside my renal corpuscle? So renal corpuscle is the first part of the nephron, which we already established. And it has two things. It has a glomerulus and a glomerular capsule. So what is glomerulus? Glomerulus is a tuft of capillaries. So basically a bunch of capillaries that are found inside your nephron. And these capillaries are of glomerulus are fenestrated, which basically means they have a lot of holes. So that's basically what fenestration implies. Now, surrounding your glomerulus, surrounding that capillary network that we have, is a little ball, little circle that protects this capillary network called glomerular or Bowman's capsule. The word Bowman is basically the name of the person that discovered the structure. So we can call them glomerular or Bowman capsule. We're starting to remove the Bowman nowadays, but still a lot of textbook uses them. So glomerular capsule, which is the shell that forms around the tuft of capillaries, actually has two layers. And these words should sound really familiar to you. The parietal layer, which is typically implies is the outer layer, and then the inner layer, which is visceral layer. So let me just show you a picture. So here is my my renal corpuscle. Okay, this whole thing is my renal corpuscle. What you see inside, the red tuft of capillary, again, is called what? Glomerulus or glomerular capillary. So I'm going to write here glomerular capillary, which in your PowerPoint are referred to as glomerulus. Okay, that's the tuft of capillary you see here. And again, you notice there is a shell around this, right? So this shell that you see right here, and right here, is the parietal layer of the glomerular capsule. So it means that's the outer layer of the capsule. And again, look at the cells. They're a single layer and they're flattened cells, which means these cells are simple, right? Single layer, and flattened cells is squamous cells. Okay. So the second layer, so this was the parietal layer. So what is the second layer? Visceral layer, which consists of podocytes. So let's take a look at this picture. Notice how you can't really see the blood vessels in red because they're surrounded by these alien looking cells that surrounds them. So these alien looking cells that you have in yellow, these are called your podocytes. So these yellow cells that you have right here are called podocyte, and they're basically your visceral layer of glomerular capsule. So far, so good? Is this making sense, everybody? So if I say, what is your renal corpuscle made up of? It has, you don't need to answer. I'm just going to repeat myself so you guys, because it's hard for people to type the answers. So if I ask you, what is renal corpuscle made up of? It's made up of two structures. The tuft of capillary is called glomerulus, and you can answer with me on your own, guys. And then the protective shell around it called the glomerular capsule, which is also called Bowman's capsule, the person that discovered it. If I say, what is your Bowman's capsule is made up of? It's made up of an outer layer, which is called the parietal layer, and it's simple squamous cells. And then the inner layer, which are these yellow alien looking cells, are called podocytes, and these are the visceral layer of that capsule. Is this making sense so far, guys? Please, if something doesn't click for you, ask questions now so I can clarify for you. No, we're good. And notice that how I mentioned earlier in the previous slide, I said that the glomerulus is fenestrated, which means it has a lot of holes in it. Look at this. Do you see all of these little pores or holes? This is what we're talking about. So kind of think about this, guys. We want things to leak out from this capillary network into this space, into your Bowman space or capsular space. And we want to clean it and then return it back to the blood. That's what we want to do. So if everything is stayed inside the blood, I won't be able to filter it. So I need to have a bunch of holes in my blood vessels so I can filter blood out of it. It's kind of like when you use a strainer to filter things or to pass things through, right? To drain water. Same concept here. So if I want to filter the blood, I need to be able to pass it through my blood vessels, and these pores and these holes allow that process to take place. Here is a picture, guys, for you guys to kind of again imagine that. Right here, we have the capillary network or glomerulus, basically this network. And then what I have in yellow, these are the podocytes. And notice again, these are basically allow me to filter things through. So these holes and the podocytes, the fenestrations, allow things to leak through and filter into that space or capsular space. This is really important, guys. This filtration process is extremely important for the functionality of your kidney. And I want to add one quick thing. So if you guys have any question related to that, you can ask. So notice how these holes are like a specific size. So kind of think about if you have a strainer, the size of the holes in the strainer can be different, which basically allows different size molecules to pass through. So under normal condition, pay attention to this, guys. Under normal condition, I want these holes to be a specific size, so I cannot pass red blood cells, which are basically my blood cells, from this side to this side. I don't want them to pass through. Because if they do pass through, eventually they're gonna be part of my urine, and I don't want that. I don't want that. So under normal condition, do you wanna see blood in your urine? I know it sounds kind of like common sense, but do you wanna see blood in your urine? No, right? Which means these holes that you have right here and right here must be small enough that doesn't allow the red blood cells to pass through. However, Think about somebody that might have a urinary tract infection, or they might have damage to their kidney as a result of somebody punching them or some sort of trauma, right? So what happens at that time, there is going to be damage to these fenestration, to these pores, and these pores can be wide open or basically be ripped apart. So in that case, what happens is your red blood cells now can pass through, right? Because the holes are like super big, right? So the red blood cells can pass through. And if the red blood cells pass through, exactly, then you're gonna see blood in your urine. So under normal condition, always when you go to do a urine test, one of the first things they check for it is, do you have blood in your urine? And you should not have. If everything is healthy and good, working good, you should not have any blood in urine. If you do have blood in urine, that typically implies, in most common cases, especially if you're a female, it implies urinary tract infection. Is this making sense so far, guys? So it always blows my mind when I think about it. So like next time, like when you guys do your blood test or urine test, now a lot of things are gonna click. Why do they care about urea? Why do they care about blood? Why are they testing for this or that? So hopefully that kind of helps you understand the reasoning behind why those tests are being done. Awesome. Okay, so the next part of our nephron, if you go back to the picture we were looking originally, we had renal corpuscle, which is what we've talked about so far. And then the second part is what we call renal tubules, which are basically all of these tubes you see from here to here. So renal tubules are the following. The path that starts is called proximal convoluted tubules, which almost universally are over shorthand that to PCT. You have the nephron loop, which basically fluid goes down first, forming the descending limb. I'm gonna scratch this out for you guys because it's not something I talk about in detail for you guys. Then the fluid starts to come up, so the ascending limb. And then it reaches what we call distal convoluted tubule, or DCT. So the four major parts of a nephron tubes are PCT, descending limb, ascending limb, and then DCT. Again, collecting duct, remember, it's not part of the nephron. If you go back to the picture again, this is my collecting duct right here, and I haven't listed it as part of the nephron. Okay, so go back to the same picture. Same picture we have. So right here, from here to basically here. See how the tubes are kind of twisting and turning? That's basically the word convoluted, right? So this is the first part of the tube that we start with. So we call it what? Proximal convoluted tubules. So the fluid is basically doing this path, basically this kind of zigzag path. Now, then again, the fluid starts to go down, right? So we call this what? The descending limb. So this is your proximal convoluted tubules. Then you have the descending limb. Then the fluid basically does this kind of a loop and then comes up. So this part going up will be your ascending limb. And then again, notice how you guys doing again this kind of back and forth nephron tubules here. So this twist and turns is now farther away. So we call this your distal convoluted tubular, or DCT. Are we clear so far? Good. Any questions? The cells that are listed here, it's not something I discussed with you guys in detail. However, whoever is going to teach you physiology may go into a lot more detail. If you were my students, I would go into like hell of a lot of detail than I have here. But for now, for the purpose of anatomy, I want you guys to just focus on what I've described here. Here's a picture of a renal tubules at 165 times magnification. So right here, you can kind of see these red blood cells inside. So this is your glomerulus. That's that tuft of capillaries. right here surrounding this, you have your glomerular or Bowman capsule. And then you have, I don't think if they listed this, you have the crossing of your distal convoluted tubule. So they cut it like this, so you only see the circle. So here's your distal convoluted tubules right here. And I don't think I have the proximal. Yeah, proximal will not make sense to you because it's kind of hard to explain how it is that. But the three that are really clear is the glomerulus, the capsular, the glomerular capsule, and then the DCT. Okay, so let's get to the fun part. So again, the first part of the nephron we have is the renal corpuscle, which has that central capillary network called glomerulus. Now, what is happening in the glomerulus is where I'm going to filter the blood. So filtration of the blood takes place during the glomerulus or in the glomerulus. So first thing that I need to do is first I need to bring in blood to the individual glomerulus. And to kind of give you an idea, each of your kidneys, guys, have about 1 million nephrons, which means you're basically gonna have individual blood vessels coming to each of these glomerulus inside each of these 1 million nephrons. Just kind of mind blasting if you look at the, the details inside of it. But basically, what is the blood vessel that is going to bring blood into your glomerulus and then take blood away from the glomerulus? So these blood vessels, and I'm going to go back to this picture right here for us. The blood vessel that's going to bring blood into the glomerulus. So this one that is coming in, that is going to be your afferent artery. Actually, let me use a different color. Sorry, one second. Or I guess I can use the same color now because I erased everything. So this one that is coming in, right, bringing blood into your glomerulus. Oh my God, I forgot what the name called. The one that bringing blood into the glomerulus is going to be called afferent arteriole. It becomes the glomerulus, as you can see, and then it takes the blood out. So this one that's taking it out is called the efferent arteriole. I always tell my students, remember E for exit. So efferent arteriole is the one that's going to take the blood away from your glomerulus. So afferent and efferent arteriole, efferent is going to be smaller in diameter compared to the afferent arteriole. And I'm not going to describe the reason behind it, but just do keep that in mind. In average, if a kidney is healthy, you generate about 1 liter of fluid every 1 liter of filtrate, I should say, every 8 minutes. And 99% of what you actually filter through this glomerulus, what leaks out of the glomerulus, actually gets reabsorbed back into your system. So think about it, basically, your kidney processes, if it processes I should say, let's say 100 liters, so to round the number, 100 liter in a day. If your kidney processes 100 liter of, which is much larger, 100 liter of fluid every day, 99 liter of that fluid is basically returned back to your body, and only 1 liter basically going to get excreted as urine. So 99% of the filtrate is reabsorbed back into your system or back into the tubules. Now, peritubular capillaries is another capillary network we have. And I want to just kind of do a quick drawing for you guys. So if this is my kidney, and I'm just going to do, sorry, my nephron, not my kidney. And I'm just going to do a very simplified version of a nephron for you. So fascinated by my own drawing. Okay. So here's my basically nephron. So here is my renal corpuscle. Here is my PCT. I didn't draw it as like going back and forth, but you know, it still applies. Here is my descending. Here is my ascending, and here is my DCT. So first thing, if I want to kind of show you, is this is the blood vessel that brings blood in. Anybody remember what that one called? That bring blood into my glomerulus? Afferent, correct. So this one is my, afferent arteriole. Here is the network of capillary, which we call glomerulus. And this one going out would be what? E4 exit. So it would be efferent, correct. Efferent arteriole. Okay. So efferent arteriole is right now not connected to anything. Afferent is coming, if I want to kind of backtrack the afferent, what comes before the afferent would be your cortical radiate artery. And I'll show you that on a picture in just a minute. So efferent as of right now is not connected to anything. So what it's going to do, and this is really important, guys, so make sure it clicks for you. Efferent artery is going to go and come around, and this is not the best, and wrap itself around all of these tubes that we have here. So it's going to do this kind of a, and my beautiful drawing kind of, kind of, my pen went awry. But it kind of wrap itself around all of these tubes that we have. So this network that is wrapped around my tube are called peri. What was the word peri means, guys? Anybody remember what peri meant? Around, correct. So look at the name guide, peritubular capillaries. So what is the name actually telling me is what? Around tubes. This is my tubes, right? The blue color is my tubes, and peritubular capillary is around those tubes. So look, if you're looking at this picture and I ask you, what are the blood vessels? Be careful with this. What are the blood vessels associated with my nephron, which we're talking about microscopic? The blood vessels associated with my nephron. We start with afferent arteriole, glomerulus, efferent arteriole, and peritubular capillaries. So 4 blood vessels are associated with my nephron, which is microscopic structure. Every other thing that I mentioned, which include the cortical radiate artery, are going to be the ones that are associated with microscopic anatomy, which means they're going to be larger and visible with us, for us. Is this making sense, guys? Any questions about this? Any clarification? Okay. So look, let me go back to this picture we were doing. Look, cortical radiate artery goes to afferent arteria, goes to the glomerulus, goes to the efferent arteriole, goes to the peritubular capillaries, and then go back to the cortical radiate vein. So literally what I just told you, this is the big picture. This is the whole picture with all the blood vessels involved in it, represented in this image. Okay. So as of right now, we know that blood needs to come to my glomerulus. Part of that blood, depending on the size of the hose, is going to be filtered through. It's going to go to my renal tubules. It's going to pass through PCT, descending limb, ascending limb, and DCT. And as it's passing through those, what I'm going to do is I'm going to reabsorb or reclaim most of those back, 99% of what I pushed as a filtrate into the tubes are going to be reabsorbed back into my system. And that is done by the peritubular capillaries. Anytime that, oh, sorry, I'm going to go back. Anything that is remaining inside my renal tubules, anything that remaining inside my DCT, eventually going to dump into the collecting duct. And a collecting duct is basically what we call urine, which basically means it's done and eventually going to be removed from our system. So we talked about peritubular capillaries. We said that these are the ones wrapped around my nephron. The only thing that I haven't mentioned with you guys is what we call vasa recta. So I'm gonna kind of go back really fast to that slide that I had here. So see how it says peritubular capillaries and vasa recta? So what is that vasa recta exactly? So for that, I'm going to show you this picture first, or this information first. When you look at your nephrons, which are basically what we've been talking so far, the nephrons can be classified based on their location and based on their job. So if a nephron is mostly located in the cortex, which were the edges of your nephron, these are called cortical nephrons. So if the majority of the structure of the nephron is within your cortex, they're called cortical nephrons. And these are the ones that are basically going to be the one that if you drink enough water, if everything is normal with your body, they're the ones that are going to be producing your urine. Now, if we're looking at the blood vessels that are wrapped around the cortical nephrons, which is these ones, these network of capillaries depicted in purple are the peritubular capillaries. Notice there is no organization to them, right? They're kind of all over the place. There's no distinctive features to them. The second category of nephron that I have are called juxtamedullary nephrons. And they're only about 15% of your nephrons. But if you look at them, they're actually the nephron loop, this part that is the descending limb and the ascending limb, are completely inside the medulla. So the juxtamedullary nephron, if you want to make a note for yourself, the nephron loop, which is again, the ascending and the descending portion, is in the medulla. Why do I care about this? It's because these nephrons are going to be extremely important for me when I want to produce concentrated urine. And when do I need to produce concentrated urine, guys? Why do I need to produce concentrated urine? In what scenario? Tell me. When is your urine really dark color and very small, or the volume is very low? When do you have that condition? When you lack water, when you're dehydrated, correct. So when you are dehydrated, basically, which is the essential point, I don't use the cortical nephron to produce urine. I'm gonna use these nephrons, the juxtamedullary nephron, to concentrate my urine as much as I can because I'm dehydrated and I wanna hold on to that water. Now, the network of capillaries that are wrapped around my tubes are gonna be much more organized. Look, they are beautifully organized, right? And they have this really important pattern, which we're not gonna get into it. But they are gonna be called what? Vasa recta. So if I ask you, does all my nephron have peritubular capillaries? What would you say? Does all my nephron have peritubular capillaries? The answer is no, correct. Only my cortical nephrons will have peritubular capillaries. Versus when we're looking at vasa recta, you're only going to see vasa recta in juxtamedullary nephron. For what purpose? What is the purpose of having vasa recta, guys? What does that network of capillary do? Exactly, it's going to concentrate the urine, which is extremely important when you are dehydrated. So don't assume they are two different things. They are same, they do the same job, as in they reabsorb things back. It's just what nephron they're associated with, cortical versus juxtamedullary. And the second part is, when are they actually going to be used? Peritubular capillary are used when you are healthy, you are well hydrated, there is no need for concentrated urine. Vasa recta, on the other hand, will be only used when you have when you are dehydrated and you need to conserve that water and you need to bring that back into your system. All right, before your mind kind of blows off, let's take a 10-minute break. So it's 10:01 exactly. So let's take a 10-minute break, be back around 10:11-ish, 10:11-ish, and then we'll continue with this PowerPoint. And then if you guys have any questions, if you guys go back and have any questions, please write it in the chat box and I'll answer them. So be back by 10:10, please. Yeah, you have to log off completely. So sometimes that's the best way to do it. Okay, so let's go ahead and continue with our lecture. So we have talked about basically the nephron. We talked about the different parts of the nephron, and we also talked about the blood vessels that are supplying the nephron. So basically, we have talked about the anatomy of the nephron so far. So I just want to show you this picture because I think this is another good picture that kind of highlights what we have learned so far. So again, we have the afferent arteriole that is bringing blood into your glomerulus, which is this structure right here. The one that is taking the blood out would be the efferent arteriole. And kind of highlighting what I've been telling so far is when you have all of these holes that are found inside the glomerulus, part of the blood is going to pass through and get into your PCT, which is this part. And anything that's basically passing through is through a process called filtration. And whatever is entering the PCT and basically going through the PCT, the descending limb, the ascending limb, and the DCT is referred to as the filtrate, because basically it's a product of filtration. And I'll talk about that in just a little bit more detail in just a minute. The other thing I want to mention, which is a really important fact when it comes to physiology, I'm not going to go into detail about this for you guys. But when I draw a nephron for you guys, typically I draw it like something like this, right? And again, this is a really simplified version. But you had basically the capsule, the PCT, right? The descending, the ascending, and then the DCT, right? That's the picture I draw for you. The reality of the nephron is that this DCT actually tucks back in and sits right here, as you can see in this picture. So here, this is your PCT, which is the first part. It goes down, this becomes the descending, it comes back up as the ascending. And then this part of the tube, which is kind of convoluted, that's your DCT. And again, it's, this is supposed to be DCT, sorry. It's tucked in right between the afferent and efferent arteriole, which is what you see right here. Again, this is your afferent, this is your efferent, and this tube you see right here, stuck right in the middle of them, is going to be your DCT. So this is your DCT. Now, without me going into details and provide physiological details for you guys, the main reason why the nephron is structured like that is because you want to basically check to make sure that the filtrate that is coming out and eventually going to become urine is properly set, and we're not losing or holding on to too much things that we don't need. So it's kind of like a checkpoint for us. Awesome. Good job, Nelson. It's a good way for us to make sure that what we're getting rid of is what we need to get rid of, and we're not doing anything wrong. And again, you'll talk about that in a lot more detail in physiology. Now, let's go ahead and take the next step. Some of the information that I have on this slide is something that I've already discussed with you guys, and the other information would be new. So when we look at urine production, so when you're looking at, when you look at the concept of urine production, we have three main process or steps that needs to be completed for the urine to be eventually formed. And these three processes are filtration, reabsorption, and secretion. So they take place in a very specific location inside the nephron. We already talked about filtration. It's what I was just showing you earlier. The location for that is the glomerulus, which just kind of makes sense. That's where you push the fluid out to become filtrate. The process of reabsorption and secretion both takes place in the renal tubules, which also makes sense because that's the only part of nephron that is left. And the difference between reabsorption and secretion is the direction the molecules are going to move. Now, the molecules could be water, ions, sugar, amino acid, anything that's basically moving. So reabsorption is the movement of nutrients, water, or essential being reclaimed, which means if you want to kind of looking at it, it means it's moving from the tubules into your blood. And the blood is basically your peritubular capillaries. And I'll show you guys in a picture in just a minute. Secretion is the opposite process of reabsorption, which means that you take things that are in your blood and you move them in your tubules. So the reason we do secretion, guys, is sometimes we have things that are in our blood that you just don't want. We want to get rid of, but they're still in blood. So the way I'm going to get rid of them is I'm literally going to put energy into it, the active process, I'm going to put energy into it, and I'm going to literally move them from my blood into the renal tubules, and the renal tubule, again, eventually becomes urine, and I'm going to excrete them out of my system. I'm going to note for you guys the secretion typically associated with unwanted molecules. The most common one would be medication. So you know how like whenever you go to a new job, they ask you guys to do a drug test. So basically what they're testing for is any type of recreational drugs or regular medication that you can test for. So that's another thing that they can measure or check for when you do a urine test. It's kind of fantastic. Okay, so what I'm gonna do for you guys is I'm gonna do a picture and I'm gonna show you these three processes. But what I'm gonna start with is the process of filtration. So I'm gonna do this big drawing. Oh, sorry, no, erase this because I don't like the color. Okay, so let's do our pen. So I'm only going to do basically the process of filtration in this one, okay? So then we have, the color changing is harder than I thought. So here is my glomerulus, this big thing, and then this is my afferent and efferent artery. Does this picture make sense so far to everybody, what I'm drawing exactly? So glomerulus, afferent, efferent, right? And then this is my glomerular capsule. Awesome. Okay. And then if I'm looking at this, this would be my PCT, correct? Now, inside my glomerulus, what I have is blood, right? Because that's a blood vessel, right? That's part of my blood vessel. So tell me, what are the components that I can find in my blood, guys? So tell me the components that are found in my blood. Tell them and I'll write them down. I'm ready. Come on, you guys know what's found inside the blood. We had a full lecture on blood. Okay, you said albumin. What is albumin exactly? And somebody says plasma. So what is albumin classifies as? And it doesn't have to be Kenya. Anybody else can answer that too. So we said plasma. So is albumin a carb, a protein, an amino acid? What is this? What is albumin, guys? It's a protein, correct. So the first component, so thank you for writing that. So the first component we have inside a plasma portion is protein. And that includes things like albumin, globulin, fibrinogen, many other proteins that are found in blood at much lower concentration, like antibodies. Somebody else said red blood cells, correct. So red blood cells. What else? White blood cells, correct. So white blood cells. Okay, platelets, right? Platelets are also very small fragments. So we're gonna write platelets here, but they're still considered part of cells, okay? What else? What else can I find in my plasma, guys? Think about, what is most of my plasma made up of, guys? Water, correct. So H2O. What else? What else do we have in plasma, guys? What is the most important nutrients I have in my system, guys? Come on. Nutrient, guys. Okay, carbs is in the right direction. Glucose is the correct answer. So glucose. And then we have things like amino acids, right? Because I need to transport those. Now tell me, guys, what is my metabolic waste products? Metabolic waste products. CO2 is not a metabolite, it's a gas. So the first slide that I talked about. So creatinine, correct. So creatinine, what else? Urea, And what's the last one, guys? Uric acid. Sorry, guys, 1 second. Okay, so I think we got almost all of them unless I missed one. Okay, so let's go back to what I mentioned earlier for you guys. We said that the glomerulus is made up of a bunch of holes, right? It has kind of holes, and it allows some molecules to pass through, and it allows the other ones to stay inside the blood and basically go out of the afferent arteriole. So my question for you guys is, based on the list I have, which component, and let me finish the things and take a moment to think about it and then give me an answer. Based on what we know about the size, which of these components should be or should not be able to pass through? So they are going to be large enough that they can pass through. Now, if you're like, well, I don't know how big these are. One second, don't answer. One thing that I want you guys to think about is that if they are large, they can be part of the filtrate and they cannot eventually be part of the urine. So if it is part of the urine of somebody that's healthy, then that means they were small enough to pass through. If they're not part of a person's normal urine, that means they were large that couldn't pass through. So my question is, which of the components we listed here should not be, cannot be passed through the filtrate and become part of the filtrate? So now list them. Okay, so I have red blood cells and white blood cells, platelets, amino acids, okay? I'm gonna give you a few minutes. Oh, not a few minutes, like 10 seconds. What else? Is there anything else that you think can be part of the person's urine? And if it's not, then which one are they? I'm looking for the not, part that cannot be part of the urine. Okay, RBC, WBC, protein, platelets, and glucose. Okay, we're hitting some of them, but not all of them. Any other thing that cannot be? Okay, so I see most of you guys get the first 3 correct, or the first 4 correct, but you also added, or I'm actually looking at Teresa's answer, sorry, putting it on the spot. But what I'm actually looking at is thinking about it in terms of size, right? So the following answers are going to be correct. So if you're looking at the ones that shouldn't be passing through because they're too big, red blood cells cannot pass through, so you guys are correct. White blood cells are even bigger than red blood cells, so they can definitely pass through. Platelets are still fragments of the cell, so they cannot pass through either. So those are the 3 main ones. So you got it right. The other one that cannot pass through if you're a healthy individual and you have no problem are proteins. Proteins are also large enough that they cannot pass through. But look at the rest of these guys. What is creatinine, urea, and uric acid, guys? What are they? Creatinine, urea, and uric acid, they're waste. So should they logically be removed from my system? Yes, so should they be filtered through? Do you see the logic, guys? The answer is yes. So creatinine, urea, and uric acid are going to be small enough to be filtered through. The other big components of what we consider urine is water, which everybody has made sense because water is going to be small enough to pass through because it's a big part of what we call urine. Now, see how I wrote glucose and amino acid right next to each other? It means they're basically the same size or around the same size. So my question for you is, if somebody is diabetic, how do we identify by looking at their urine? How do we identify somebody is diabetic by looking at their urine? They have a lot of glucose in their urine, correct. So basically, I'm saying that glucose is small enough to pass through if I have too much of it in my system, right? So if glucose can pass through, then amino acid can pass through. Here's the thing, guys. Well, yes, body's trying to get rid of too much, or the body cannot reabsorb it back. That's a better way of saying it. Ketones in urine is also true, but since nobody knows what ketones are unless you have actually lectures on it, I'm not going to get into that. But yes, you are correct. So when you're looking at somebody that has diabetes, there's nothing wrong with the glomerulus, right? They just have too much sugar in their system. So glucose is one of the components that is going to be filtered. However, is glucose important for us? Correct. So what do I want to do? I want to bring all of it back into my system. So if you're healthy, pay attention to this. If you're healthy, glucose is going to be part of your filtrate because it is small enough that it's going to become a filtrate. However, because it's such an important component for our body, we're going to reclaim all of it back into our system or reabsorb all of it back. Same thing with amino acids. Amino acids are used to make what, guys? Why do I care about amino acids? What do they make for me? Proteins, correct. So I just ate a bunch of proteins and I break them down to amino acids. I don't want to get rid of that amino acid. So what do I want to do? Again, reabsorb it all back into my system. So now think about this, guys. We say anything that is going to pass through here is going to be part of my filtrate. Okay, so water is going to be a big part of filtrate, glucose, amino acids, And then I'm just gonna say waste products, so you guys can say that that's creatinine, urea, and uric acid. Now, the only thing that I forgot to list here, which is an important, I was like, I keep thinking, I'm like, there's something missing from my list. The other component of the plasma that we have, and I'm just gonna kind of move it up here, that we have here is your ions. So what are my ions, guys? Give me some example for ions. We have talked about it, like literally the first topic that we talked about for this lecture. Things like sodium, potassium, calcium, chloride, etc., right? Right. So all of these ions are also going to be small enough that they're going to be part of urine. And again, kind of think about it. We said that your body is going to be able to balance these, which means they need to come out if they're extra, right? So salt, like things like sodium, potassium, calcium, these are also going to be filtered through. And we're just going to absorb whatever we want and then get rid of anything that is extra. Is this making sense to you guys so far? Is this any questions? That's just something just doesn't click for you right now. Awesome. Okay. So what I've described here is the first step, which is in urine production, which is called filtration. Awesome. So next thing that we have, and I'm going to add another screen, is the process of reabsorption and secretion. So let's draw our tube. So I'm going to go back to drawing our tube. And again, this is a really simplified version, but it kind of show you what we want to show, hopefully. So based on this, if I say kind of this is where my thing is, where my glomerulus is. So we have PCT, right? Then we have the descending, we have the ascending, and then this would be my DCT. So far, so good? Now, what parallel to our renal tubules or surrounding the renal tubules, I would have my network of capillaries, which again could be peritubular capillaries because that's 85% of our nephron. So we're just going to go with a common one. So I'm going to say these red that I'm drawing parallel to these. Again, normally these would be a lot more sophisticated. They wrap themselves around. But for the simplicity of our purpose, for our lecture, we're just gonna kind of draw them like this. And these are going to be my, peritubular capillaries. So in here, in my PCT, I'm gonna just rewrite what we have done on the previous slide to kind of bring it everything together. Right here, I'm gonna have my filtrate, which is going to be water, waste, ions, glucose, and amino acids. And I think I got all of them. So as this fluid, this filtrate is passing through the PCT, descending, ascending, and DCT, some of the things are going to be reabsorbed. So what is going to be reabsorbed in each part is what we're going to focus on. So I'm going to do an arrow coming out from the PCT into the peritubular capillaries. So these arrows that are going from PCT to peritubular capillaries show the movement of molecules from one area to another. So what do you think this represents, guys? Reabsorption or secretion? Look at the direction of the arrows. Is it reabsorption or secretion? Reabsorption, correct, because I'm returning things back to the blood, right? They came from blood. Now I'm going to return them back to the blood. So what am I returning only in the PCT? This is really important, guys. In the PCT, I'm gonna return 100% of my glucose and my amino acid. So 100%, if you're a healthy individual, all of the glucose and amino acid that was filtered is gonna be reabsorbed back into my system. And I'm gonna say the purple arrows, by the way, just kind of highlighting for you, it's highlighting reabsorption. We are also going to reabsorb 65% of our ions and 65% of our water. So PCT is gonna be super essential in terms of reabsorption, right? 100% of glucose and amino acid and 60% of our ions, 65% of ions and water. So when we get to the descending limb, so again, we're gonna have reabsorption happening. And here is a really important factor here, guys. In the descending limb, sorry, just keep an eye on the time. In the descending limb, the only thing that is going to be reabsorbed is water. So all of these arrows represent water being reabsorbed into my system. Now, the amount is not gonna be a specific. Why is 65%? That's just how it is. This is basically based on the measurements we've done on the urine. A PCT is responsible for 65%. You remember, you don't want to reabsorb a lot of water because it depends on how much your body needs water. But in average, you absorb about 65%. So kind of think about this, guys. As I'm going through the descending limb, I'm reabsorbing water, right? So tell me, by the time filtrate reaches this point right here at the bottom of the nephron loop, what is the concentration of the filtrate? Is the filtrate super concentrated or super dilute? By the time the filtrate reaches this point, is it super concentrated or super dilute? It is concentrated, right? Because what did you do, guys? You remove a lot of water from it, right? So basically what you have left with is a lot of, ions, waste products, and very little water. So at this point, I'm gonna kind of make a notation for you guys here. At this point, at the bottom part of this, you have the highest concentration of filtrate. So your water is taken out, and therefore the the filtrate become concentrated. No, we don't get rid of all of it. Sorry, going back to Nelson's question. No, we don't get all of it. Most of the water that gets into our filtrate gets reabsorbed back into our system. Okay, now as we're gonna go up through the ascending limb, still we're gonna continue reabsorption, right? So here's my reabsorption. So reabsorption in the ascending limb is gonna be limited to my ions. So again, ions are like salt, sodium, potassium, calcium, chloride, etc. So as we start to go up, we reabsorb the ions. So again, you go back to that dilute sample of filtrate. So if you start, and I don't want you guys to memorize these numbers, but these are actual numbers. So if you start up here about 200, by the time you get down here, you're at 1500. By the time you go up here, you go back to 200. Because you get rid of water, you become super concentrated. Then you get rid of the ions, then you get super dilute again. Sorry, I'm reading the question. When we PV use water again, I don't know what that means exactly, sorry. So can you reword your question for me, Nelson? Okay, so up to this point, we have reabsorbed a lot of material back into our system. Again, we're kind of going back to that 99% of the things being reabsorbed back into our system. So what about our DCT? What is happening in our DCT? DCT is really particular, guys. So DCT reabsorbs, I'm going to write this down, water or ions depending on the need of the body. So remember earlier I said DCT is tucked in under between the afferent and efferent arteriole. So basically that's your checkpoint. So let's say you get to the DCT and you're doing your check and you say, oh, I need to reabsorb more water. So when your body notices that, it automatically secretes a hormone called aquaporin. Secretes a hormone called vasopressin or antidiuretic hormone, and that causes your DCT to start absorbing more water back into our system. Let's say your body notices that your sodium is low and you need to reabsorb more sodium. So it literally has mechanisms that allows the sodium to come in back into your system. Let's say it thinks that your potassium level is high, then it's gonna excrete potassium at a higher level. So when you go through PCT, the descending limb and the ascending limb, you really don't have a choice. Those things are gonna happen regardless of what your body needs. By the time the filtrate reaches the DCT is a determining factor. It says, okay, let me see what I need or what I don't need, and I'm gonna get rid of those or hold on to them respectively, depending on what my body needs. Okay. Okay, Nelson. Is this making sense, guys? Is this so far make sense? Is there anything that needs clarification? So these are exam questions, guys. Be comfortable with this. So if I say, which part of your nephron tubules reabsorb 65% of water, then your answer would be? Your answer would be? No. The question is, which part of the nephron tubules will be reabsorbing 65% of water? Only PCT, correct. So PCT is the only part that reabsorbing 65%. That's the magic number. What if I say, what's the part of the nephron that only reabsorb ions? Only reabsorbs ions. Ascending limb, correct. So ascending limb is the only part that is reabsorbing only ions. So the keyword is, am I doing this and that? Or am I just doing one thing? Or am I doing the specific percentage? Which part of the nephron tubules determines that I might need more sodium and therefore reabsorb more sodium? That's DCT, correct. So think about this, guys, logically. Up to DCT, everything happens automatically. You really have no control over it. Up after DCT, you kind of go like, okay, let's see what I need, what I don't need. Let me balance everything out before I sending it out. Okay. Now, the last thing I want to kind of add to this picture is, I want to see color, is the last part on urine production, which is what? We talked about filtration, reabsorption, so what's the last part? Anybody? Secretion, correct. So secretion, again, it's something that if I don't want it, I want to get rid of it. Most of the secretion takes place in the DCT, PCT, sorry, DCT, descending and ascending limb. And I'm not going to write specific things about them because there is no specific molecule. It depends on what you have in your body and what your body doesn't want or wants to actively get rid of. But again, look at the arrows, guys. Compare the purple arrows to the white arrows. The direction of the arrows are completely opposite. And the last thing that you really want to know about the secretion is that this is an active process, which means you must input energy for this event to take place. It doesn't happen like everything else that I described, it just happens on its own. Are we clear about this? So please, guys, make sure when you guys are studying for your last lecture exam, come back to this recording. Make sure you guys are very comfortable with this picture, because most of the pictures in a textbook doesn't really bring everything into these images. That makes it a little bit easier for you to follow. This is what we already talked about, right? This is really identical to what I've drawn, but in a picture format for you. PCT is literally what I've just talked to you guys. PCT, descending, ascending, and then DCT. So this is the writing version of what we did on the drawing right now. Here is kind of like the crude drawings for what we talked about for the PCT. Here is the crude drawing for the water and ions being reabsorbed in the descending limb and the ascending limb. And again, kind of notice the numbers, I kind of hide them, but right up here, you can see it's about 200 to 300. And down here at the bottom of the loop, you have the 1200. Okay. I'm gonna try to just finish this up because then we can have a shorter lecture next time. Ureter, so kidneys produce the urine, we're good. The collecting duct has done all of their job. Now the urine is gonna be picked up by the ureter. Couple of things you need to know for the ureter. There's not much things you need to know. First of all, when it enters the kidney, it comes in an oblique angle. So it comes like this. When it comes to the bladder down here, that kind of helps to make sure that the urine doesn't backflow up toward the kidneys, which is something really bad. The histology, you have the mucosal lining, which is basically made up of transitional epithelium that allows the bladder to basically grow and then kind of collapse on itself. It has muscularis, which basically means it has a smooth muscle. Let me just make a notation for you guys. So it has these muscles are smooth muscles. Basically make sure that urine is moving down. And then the outer layer, this is the outer layer, is adventitia, which is made up of connective tissue. And that's all you need to know for ureters. It's pretty simple. Urinary bladder, a couple of information about this. It is responsible for storage and expulsion of urine. When the bladder is full, it is a spherical, but when it's empty, it literally kind of like an empty sac or like a balloon. It collapses on itself and it sits on the pelvic cavity. When it gets full, it gets pushed up into the abdominal cavity. For the male, as the urinary bladder continues to become urethra, the beginning of the urethra is surrounded by the prostate gland. So kind of showing you this. Here is the bladder right here. Here is the urethra that starts basically from here and continues all the way here. So this tube you see right here, the red ones, that's the urethra. And this circle, it's about the same size of a walnut. This circle you see right underneath it is the prostate gland. So when you compare the male and female urinary and reproductive system with each other, the main difference would be the presence, one of the main differences would be the presence of the prostate gland right underneath the bladder. Kind of interesting information, because especially if you're around like your parents, your fathers, as male age, this is like one thing that I guess male have to deal with, unfortunately, but it's basically enlarged prostate. So under normal condition, here's the normal prostate. It doesn't put any kind of obstruction on the urethra. If a person, as the person ages, basically typically about 50% of male between 51 and 60, they're going to observe that enlarged prostate, which basically pushes down on the urethra. So in this case, it's going to be kind of hard for the bladder to empty, and that causes the frequent urination in case of older men. It also, the way that they might signal prostate cancer when they have significant elevation on a hormone called PSA, and that typically target or implies prostate cancer in the case of male. FYI, prostate cancer are actually, there are three main categories. There are ones that are like super slow, and then the ones kind of in the middle, and then some that are relatively fast and very, very dangerous. Most of the prostate cancer identified in male, basically they won't do anything. They just kind of monitor the PSA level, and they go from there. But for most part, they don't really do anything if there is a prostate cancer that is slowly moving. We'll talk about the function of prostate next time. It actually contributes significantly to the production of semen. Yeah. So about 40% of what we consider semen comes from the prostate, which basically ensures that the sperm can survive in the female reproductive system. Urethra is another structure that we have. So urethra is basically the tube that excretes urine out of the body. Interesting fact about the urethra. So again, if you this is the urethra, and the bladder would be up here. You can basically break it down to three parts. The top part, in terms of cells, are very similar to what we talked about for ureter, which is transitional cells. Somewhere in the middle, you have two types, a stratified and pseudo-stratified columnar, which are kind of these elongated cells. And then a stratified squamous all the way toward the end, where basically opens up to the outside. And the main reason why we have a stratified squamous epithelium is for protection. Again, the more layer cells you have stacked on top of each other, the better you have in terms of protection. Like what we talked about digestive system, remember we said there are two types. There are two types of sphincters. The inside one, internal one, is involuntary smooth muscles. That's basically the one, and I'm sorry for saying that prevents leakage. And this muscle in many females, especially after childbirth, becomes relatively weak. The second one is the one that is the external one that you can practice with, and that's the one that's voluntarily inhibit urination. So basically when you decide to pee, that's the one you relax to allow you to pee. Very scientific, sorry. Now there is, again, if you're comparing the male versus female urethra or urinary system, female urethra is significantly shorter, so it's about 3 to 4 centimeters, versus in males it's about 20 centimeters because it has to go through the length of the urethra. So in females, this is the urethra basically, versus in males, it has to go through the length of the penis, and it's typically longer than women. We already talked about the presence of the prostate gland. One thing that differentiates again between male and female is, for female, we said they have a urethra, which is simplified. For male, they actually have three. If we have one urethra, but they have three parts to it. The first part that passes through the prostate is called the prostatic urethra. The part that passes through a membrane called urogenital diaphragm is called membranous urethra. And the part that passes through the length of the penis is called either penile or a spongy urethra. So do keep that in mind as well. Sorry, I don't know how many more slides. I don't want to go over the time. What time is it? All right. Let me just finish this up because otherwise we have 2-3 slides left for the beginning of next class. So urinary tract infection or UTI. unfortunately very common in females. It is simply put infection of the urinary system. Most of the time when we talk about urinary system, it's limited to bladder. But if it's not taken care of, it can eventually go to your kidney, which is really, really bad, guys. Kidney damage can also, that can actually lead to your kidneys shutting down. So if you are diagnosed with UTI, if you have symptoms like burning sensation when you pee, you have to kind of continuously go, go, go. If you have pain when you're urinating, if your urine has that cloudiness to it rather than that clear solution, these are typical signs of UTI. So please go see your doctor, go to urgent care and get a $20, antibiotics. It's a 14-day antibiotics, and you better deal with it sooner than later. The main reason it's going to be bacteria that causes the UTI. As I said, females are more susceptible to it for two reasons. One, they have a shorter urethra, so kind of you're really close to the outside, which makes it really easy for the bacteria to travel, versus the much longer urethra in male. And then the second one is proximity to anal canal or anus. Anus. So basically fecal matter can get into the urethra and cause infection. So as a woman or as a girl, female child, one of the first things you learn when you get potty trained is always wipe from front to back to basically make sure you don't introduce any contaminants into the urethra. And again, typical treatment is antibiotics. I don't know if anybody has heard of it. Take cranberry juice, like if you have a UTI. Have anybody heard of that before? So I'm going to caution you against that, especially if you're a female. Cranberry juice that are sold in the market are really high in sugar, and sugars are really good for bacteria growth. So if you have a UTI, you probably have leakage of sugar into your urine, and that makes it a very good environment for the bacteria. So we would avoid taking cranberry juice. And yes and no. So my recommendation, this is based on what I have heard from multiple doctors, is to take cranberry capsules, which is basically cranberry that does the job by creating an acidic environment, which is not ideal for the bacteria, without the added sugar. So if you are even to take cranberry, take it as a supplement rather than as a drink. And honestly, if you have ever looked at the sugar content for those, you really don't want to drink the cranberry juices that are on the market. If you buy, I went to like one of those wholesome, whole choice, whatever, organic stores once, and bought like a container of it. It's extremely expensive if you want to buy the pure one. Unfortunately, actually, I don't think Trader Joe had it. I think it's like Mother's Market or something. It costs like $15, honestly, waste of money. But it actually tastes like super sour. It's really difficult to drink it. But that's the one that doesn't have added sugar. So if you really want to drink it, that would be your best one. Or just chew on cranberries, I guess. That's your other option. Okay. Acute renal failure is another one that we have. So acute renal failure is basically when the kidneys just shut down. It's not a chronic condition, again, that takes a long time. It's an abrupt process. In such a cases, if you have what we call ARF, urine volume almost decreases to completely non-existent, especially if you are, the condition is affecting both kidneys. One of the main reasons that can lead to ARF is, let's say a person's been in a car crash and they have lost significant amount of blood. Or they have had a burn, that third-degree burn over most of their bodies, that can lead to shutting down your kidneys. Kidney stones can lead to ARF, but it's less likely than the significant drop in blood pressure or blood volume. What do you see if somebody's kidneys are shutting down as a result? You're going to see edema because the bladder is unable to get rid of that extra water. So water stays inside. Acidosis, basically, again, unable to balance your pH. So the acidic components stay inside. Urea buildup. Again, urea is a waste product. I want to get rid of it. So if they stay inside my body, you basically have a buildup of that. Anemia, one of the hormones, I don't know how well you guys recall this, one of the hormones that are essential for blood production is a hormone called EPO, or erythropoietin. If your kidneys are basically not doing what they're supposed to do, they won't be able to produce this hormone, so your blood production decreases. And unfortunately, believe it or not, kidney failure can lead to cardiac arrest. The main reason has to do with potassium. If you have too much potassium in your system, that can cause the cardiac arrest. It's kind of like the injection they give to people who are on death row. That's what they actually give them. They give them a high dosage of potassium, which kind of stops their heart. So if your kidneys are basically unable to do their job, they can lead to cardiac arrest. I bet none of you guys see that done before. And then best way to treat it, basically get a new kidney. So these people are going to be on the top of the kidney transplant list, because without that, they would not be able to survive longer. Well, again, if you have a healthy kidney, you shouldn't really worry about it, because then it would balance it. But if you are on dialysis, one of the things I tell you to avoid is food that are high in potassium, which also includes citrus fruits. So oranges, grapefruit, tangerines all can lead to high levels of potassium. Chronic renal failure is a slow loss of functions for the kidneys. There are multiple stages. Again, usually you don't see your kidneys going into chronic until like they have lost at least 75% of their function. Then you have what we call renal insufficiency, which is basically, again, you continue losing the function. And then lastly, you end up in the end stage renal failure, which is about 90% of the kidneys or nephron have been destroyed or non-functional. The rate of filtration is about 15% of normal, which is significantly less. You can imagine how much of the toxin and things are going to remain inside the body. Very unfortunate. Treatment, again, kidney transplant. But again, these people typically have to wait longer, because the kidneys are still partially functional, and they can rely on dialysis for kind of helping out the process. This is the one that really creeps me out. It's one of the most unfortunate conditions you could have. This doesn't normally develop unless you have the genetic disposition to have it. It's called the polycystic kidney disease, or PKD. So this is a normal size of a kidney, which is about the size of your fist. And this is a kidney that has many, many cysts growing on it. So this size of the kidney is about a little bit smaller than the size of a football, which is a pretty large size kidney. Can you imagine that being in your back, right? It is, again, inherited. It eventually leads to renal failure, as in kidney will shut down. I mean, you can imagine this kidney being work normally, right? That's just kind of unimaginable, I guess. What are the symptoms? Hypertension, because again, you're retaining a lot of water in your system. You're going to have significant back pain, because again, you have a gigantic organ in the back and causing a lot of pain in the posterior region. Because the nephrons on these type of kidneys are not very good, you're going to see a lot of blood in the urine, because again, they can't filter properly. There is no cure for it technically. What they can do is to help you treat some of the symptoms, like eat little salt, so your body doesn't have to get rid of it, and then taking drugs for hypertension and pain, basically. So not much you can do. And then dialysis that I mentioned earlier, basically, again, this is a process that people, it's actually, the full name is hemodialysis, which basically means cleaning up blood. It uses an artificial kidney machine to basically filter. Some of the more complex ones actually help you also buffer by maintaining your blood pH. And they also get rid of your nitrogenous waste like the urea, creatinine, uric acid, etc. Unfortunately, again, people who are already on dialysis, unless they receive a kidney transplant, their condition will continue to degrade until the complete loss of function for the kidneys. So I hope nobody has to suffer through that or see any of their loved ones suffer through that, because it is not a pleasant thing. And then last one is how does your urinary system changes over time? So again, like every other system, as you age, your kidney functions and your urinary system function declines. Nephron decrease in size and number. So basically you cannot do filtration effectively. Tubules are going to be less efficient in bringing things back into your system and getting rid of things that are unwanted. So all of these basically result in a blood that is not as clean. The desire to urinate is also delayed. So basically bladder may stay full longer, which makes you more susceptible to UTI as you age. And then loss of muscle tones in bladder. And there are a lot of new things that are out there that kind of help you not tone your bladder, but tone the muscles that basically help you with urination. I saw this really funny thing that there's these, like when you do your collar movement, it is this bird that goes up and then comes back down. Like, they come up with some cool ideas. But anyway, so that's about it for our lecture. Anything you would like me to go and answer questions? I know, sorry, I've went a little bit over. But at least we don't have to do this next time for the last few slides. Okay, no questions? So let's go ahead and take our break until 11:25, and then we'll come back for our group lab activity. I'll break you guys to the same group as you had before. So go enjoy your break for the next 15 minutes, and I'll see you then.